Hi everyone, my name is Zeng. I'm a second-year internal medicine resident at Scripps, and so my poster today is titled as ICI-Induced Myocarditis when chest pain is not due to a blocked vessel. So my focus in bringing this case presentation is to highlight that in patients with a history of cardiac disease but are placed on immune checkpoint inhibitors, it is important that we have an expanded differential and not just think of MIs or cardiac diseases when they present with chest pain, which is sort of the situation with our patient. So this is our 84-year-old. She has stage 3 non-small cell lung cancer, and in addition to chemotherapy, she was started on durvalumab about 3 weeks prior. She then presented to the important in her past medical history is that she actually has 8 stents. So a very strong cardiac history, and so she presented to the ED about 3 weeks later complaining of chest pain. And in terms of the workup, we show that troponin was elevated, there wasn't any EKG changes, but given her cardiac history, very strong concern for that, it's a ACS of sorts. Well, cardiology took over. They did a left heart cath. They actually did find a small partial blockage in the marginal, but it didn't explain her severe chest pain. And importantly, even after they stented it, the chest pain didn't resolve. Then about 24 hours later, she went into secondary heart block, and then shortly after that, she went into complete heart block, resulting in them having put a pacemaker in about 2 days later. Now, at this point, things were getting a little bit odd because why is she having such weird chest pain? The multidisciplinary round was consulted, and including oncology, but at that time, just given the circumstances and her strong cardiac history, they thought that it was still related to ACS versus something else. Well, thereafter, she was continuing in the hospital, and it was only around day 12 that we noticed, well, she started having bulbar symptoms, including droopy eyes, a little difficulty with her shoulders, worsening breathing. And at that point, neurology was consulted, and they thought, oh, she actually has myasthenia gravis. And so taken together now, we realized that collectively, her symptoms of the chest pain, sort of the weakness, as well as the neurological is consistent with triple M syndrome, which is myocarditis, myositis, as well as myasthenia gravis, which is a pretty lethal complication, but also very rare complication of immune checkpoint inhibitor therapy. Now, and ultimately, unfortunately, because of her late diagnosis, patient passed away. Now, sort of the takeaway point is, as I alluded earlier, is because this patient, triple M syndrome or just ICI-induced myocarditis in general, tends to happen more if a patient has a known history of coronary artery disease or the such. And so it's a little counterintuitive because you think a patient is coming in with chest pain and they have a cardiac history, but because they're on immune checkpoint inhibitors, suddenly you actually have to expand the differential such that it may not actually be it may not be a cardiac etiology because of the unique circumstances. And so just a little more into, if we look into ASCO guidelines, honestly, our cardiologists did everything that a normal cardiologist would do. But if we're thinking from a purely ASCO and kind of taking into account her ICI exposure, then importantly, one of the things they do recommend is actually starting prednisone really early, within 24 hours, just even empirically, you're just as a suspicion of it. And the reason behind it is that these, the side effect of giving early prednisone is relatively benign compared to, the possibility of death. And then the other thing they could have done, perhaps, in addition to all their, excellent workup in terms of the ACS workup, is maybe send a CK, because that would be, if that's elevated, that may be more consistent with myositis. Then suddenly this patient has both myocarditis and myositis, so then maybe it's less ACS-esque. And then lastly, another thing that was sort of subtle was that she did come in with some elevated transaminitis, which has continued to rise. And that's likely, in this context, suggestive of RA hepatitis. And so, a subtle kind of a learning case where they did everything you should do for a typical ACS patient, but probably not enough when it comes to a patient with cardiac history but is also on immunotherapy.